now hand over to RCN President Anne-Marie Rafferty.
Thanks very much, Sarah, and a warm welcome to everyone. I'm absolutely thrilled to be here, and I'm going to be interviewing our stellar leaders, Dr. Chris Carter, who has been very much involved in the clinical academic side of COVID, but is also an expert, a matron in critical care at Lewisham and Greenwich NHS Trust, and a member of our international committee here at the college, and in fact has been setting up training resources and courses and infrastructure for critical care and building capacity in Zambia. Rose Gallagher may be known to a number of you through her amazing work as well in infection prevention and control, and the leadership that she's provided to the college in orchestrating its response to a number of pandemics, MERS as well as Ebola, but most recently the COVID response, and indeed coordinating the college's operational agility to the pandemic with other governmental agencies. I should also have said that Chris is also a senior lecturer at Birmingham City University, so he's got many hats as a clinical academic, and I think with Rose we are very much covering the policy as well as the clinical interface. Rose also is an expert and has been working very closely with government on procurement and sustainability policy as well, which is highly relevant to this field. So really, without any further ado, I'm really grateful to our speakers for being with us this evening. Perhaps we can just move into the interviews themselves. I will be interviewing both Rose and Chris. We'll start with Chris for about 25 minutes, and then we'll move into a Q&A. And if I forget anything, I'm hoping that Sarah will rescue me and tell me the do's and don'ts. So looking forward very much to our conversation. Now, the first question to Chris really is, what was your first memory of COVID? What really sparked your sense that something was different, was going on? How did you first hear about it? And when did you realise that what you were hearing about was in fact something quite serious and a pandemic?
Firstly, Anne-Marie, thank you for inviting me here tonight. So my first memory, I think, or recollection of COVID was I was actually completing a project in Zambia at the time, and that was in February of this year. And it was actually when it was all in the newspapers about the this new disease that they found in Wuhan in China. And so it was all being sort of, it was being discussed, but hadn't quite hit Europe at that time, and we were traveling. And I remember going through Nairobi International Airport, and it was all the posters were going up, we were all getting temperature checked. And I remember talking to our partners in Zambia, and we were saying, is it going to be like SARS? Is it going to be just a regional area? And then when I came back to the UK, I started getting lots of telephone calls from the hospital saying, are you available to come in and do shifts? And I was like, oh, I've just come back from traveling, working abroad, And then when I went in and then saw what was going on in the hospital, I think that's when it hit actually what actually was going on. And actually this is far bigger than I think anyone initially thought. And I think to provide some context, so Southeast London was quite, I think everywhere in the UK was badly hit, clearly, but South London certainly was some of the busiest critical care units in the whole of England. And when I was looking back through some of the data that from that time, we were actually, the hospital starting to get filled up and intensive care was filled well before lockdown had actually come in. And at the time I was doing a variety of roles, and the first few sort of shifts I was doing was as a critical care outreach nurse practitioner, so I was going on the wards, and certainly my colleagues on the wards were seeing large numbers of patients coming into the hospital. And I just remember going on to the admissions ward and just seeing bays of patients sitting bolt upright on a non-rebreathe mask in respiratory failure. And I think it was that defining moment where you think this is going to, this is just the start. And then gradually we started, and then the speed at which it happened, this wasn't sort of over a course of weeks, this was over a course of hours. Patients were getting intubated one after the other, going up to intensive care. And other hospitals in London hadn't quite grasped, I think, what was going on. Like I said, we were surging long before lockdown had actually really started in the UK. So on the 12th of March was when our first patient was admitted to critical care. And by the 18th, we had over 10 patients on the unit. And the UK didn't go into lockdown until the 23rd of March. And at the time, I remember there was big discussions going on between the consultants and the senior nurses. And in the region, people were saying that we were intubating too many patients. Lewisham's just a district general hospital. It's just they're not sure what's going on. They're being overcautious. And a group of consultants came down, and I remember them standing on intensive care, and it was through the PPE, you could just see their eyes, and it was just, would you intubate this patient? What would you do? Taking them down to the admissions ward and seeing those patients saying, what would you do with them? And then that was when I felt London just changed. Within 24 hours, we were decompressing the unit. So beds had become made available all over London. So as patients were coming in, because we were intubating like 7 patients a day, it was just the volume of them coming through the doors. And they were coming up, and they were 45 minutes apart coming up onto the unit. So it was just constant. So we were always trying to create additional beds. So we were opening recovery, we were opening dependency. We were always trying to find additional capacity for all these patients. And I think for me, right at the start, it was a strange feeling, because the whole of the UK hadn't locked down yet. We hadn't started seeing the large numbers, but we were seeing them. And then it was very strange to get on a bus and come home and just see everyone coming home from work. And it was like the sense of normality behind the sense of a pandemic. And then after that, that was all in that period just around lockdown. And then suddenly you felt a whole shift in London and the UK response. And so for me, it was sort of maybe a bit earlier.
Yeah, you were ahead of the curve. And I mean, it must have been quite surreal, that disconnect between what was going on nationally and what was going on locally for you. And then that sort of super surge inside your organisation. Tell us a wee bit about your role within the response, in terms of leadership and support, or what were you actually, I use the word charged in a positive sense. What were you expected to do? What was your role, Chris?
So initially I was, because we just needed staff, and that was a real pressing issue. So at the start, I was covering shifts on the outreach team, and I was covering shifts on intensive care. And so it was very much at the bedside, patient facing, and really just using my skill set as an intensive care nurse. And I can remember one shift coming on in the morning, and then I finished about 4 o'clock in the morning, because we were transferring patients all over London. And I can remember going into Guy's, which is a tertiary hospital, but it doesn't have an emergency unit, and there was like these 18 empty beds, and it was just like, and I just going back, bringing more patients, and the staff saying, it was like, there's more coming. So that was very much, the start was very clinical focused. And then we started to try and, as we recognise actually this is not going to be a short surge for a couple of days. Now we're in it for the long haul. We then had to start thinking about getting staff to be redeployed. So we ended up in this challenge of we needed staff, but actually you can't just move staff. It's not fair to move them. And, you know, it's a new virus. We didn't necessarily understand it. People don't necessarily want to work in critical care. So I ended up leading the education piece, which involved setting up an orientation and workshop and getting an education team together across both sites to actually help prepare people to go into to work in intensive care. And a lot of it was very much around allaying fears, because there'd been so much communication around redeploying staff, you know, dropping the nursing ratio in ITU, and, you know, getting left with a ventilated patient. There was so much fear around that. And actually my whole discussion with the chief nurse was around, we just need to have, you know, just talk to people and say, this is what we know, using photographs to sort of say, this is what an intensive care bed looks like, this is what your role is going to be, you are not going to be left unsupervised, you are, and really just getting people's confidence to get them into the unit. So that was very much the first part. And then as the pandemic continued, then I was seconded in as the second matron for critical care at Lewisham. So that allowed us to have 7-day-a-week cover to provide support for the sisters and charge nurses on the unit. And then so we were almost like just keeping the operation running and being the conduit between the command teams on the outside and the inside, and very much moving into that, just trying to keep the service running, keeping staff going, keeping all the supplies coming in, and just really sort of genuinely trying to support staff and help out as much as you could.
It sounds, you know, hugely demanding. What were you feeling at the time inside, you know, yourself? Were you thinking, yikes? I mean, probably a whole mix of emotions. What was it like from your point of view?
It was definitely a roller coaster of emotions. I mean, as many people may be aware, you know, my background is in the army. So to me, it felt very much like I was going on a deployment. It was that short, sharp activity where you just, you know, and it was 50, 60-hour weeks, every day, a long day, weekends, you know, and it was just, and I felt very much like it was in that, you know, it's that adrenaline rush, just getting things done and getting things through, you know, and it was very much, I think, that military feeling to it, actually. It was like being on and off. But I think it was also challenging because I think all the support networks have been taken away as well. So I think, you know, at the time when we think about lockdown, you know, things like the bars had closed, restaurants, gyms, so all those releases that you sometimes had out of work weren't available. So it was, you know, it does catch up with you because you literally just slept, worked, and it was like this cycle. And I don't think anyone's had it easy, because I think if people working from home have had challenges of staying indoors, but it was just like this cycle, and there was no real way to sometimes vent some of your pressures. And for the staff, it was like every day, both my colleague Martine, who was the other matron, was every day coming in smiling, just trying to just, you know, keep staff going to work. I mean, I think the big thing I can, from my own perspective, from what I saw, you know, critical care was hit, but you know what? Everywhere, every part of that hospital was hit. And, you know, I look at some of my colleagues, like on elderly care wards, who had to basically turn them into palliative care wards, dealing with a new virus, with patients that are young, in their 40s, 50s, you know, and they just stepped up to the mark and delivered. And, you know, you think that strength, that moral, you know, that can-do willingness, I think it was across, and it was things like that when you saw activities, you know, people like that sort of gave you the confidence to go in. I remember there was one day and we were really short, and it was, you know, and it was, you know, you just think, how, because everyone comes to you with the problems. So how do you do, you know, how do you keep the staff going? How do you keep patients safe? And then the sister from the surgical pre-assessments unit turned up with her band 6s, her band 5s, and her healthcare assistants. And they just turned up and said, we're here to help. And, you know, when you just have that ray of just, thank you. And they were just like, look, we're outpatients, we don't do, and it was just like, just go in there and hold a hand, just go be with a patient, just just go in. And so there was very much that teamwork where you just think it was just, some very inspirational people that just, that the strength of the nursing workforce was amazing.
Sounds extraordinary and brilliant, and the whole cocktail of emotions that it was generating. What about, or when did you begin to realise, Chris, that there were maybe some groups that were more affected than others in the pandemic? You've got all this going on, and how you're trying to sort of track and make sense of, if you like, the sort of epidemiology of it as it's impacting your locality. Was that something you were aware of, or was it just like, getting through the shift and getting through the day? Did you notice that perhaps some groups were more vulnerable than others?
I think we initially started to notice there was, like, I used to refer to it as the triad, which used to be the hypertension, obesity and diabetes, and you used to find that there was either 1, 2 or 3 of those linked to it. So, very much certainly early on we saw what we referred to as the triad in patient groups. One of the things that critical care in South London was very strong, and we had the critical care network, and so there was this WhatsApp group which basically everyone was sharing their data, and so there was, and then that was coming out through ICNARC, which is the research and audit. So we were getting, almost as the evidence base was evolving, certainly in critical care, we were starting to get demographics and sort of that information was feeding through and saying, actually, we are seeing that population there. I mean, we know that, people that from the BAME background sort of are in that high risk group. And certainly that was something that we were becoming more and more aware of, that was coming out in our patients that we were seeing, and also it was coming out in the literature and things like that. And that was a stress for us, because actually South London has a high BAME background. 72% of the critical care nursing workforce at Lewisham subscribed to be in that group. So there was, that's the majority of that 72%, exactly. So there was a lot of uncomfortable conversations, stress, concerns, that we were trying to manage, and it was just, it was very difficult for you, to do it. But like I said, we were lucky in some aspects, because none of our staff, only one member of staff, got COVID and survived. We did have other healthcare staff who unfortunately did die on our intensive care unit. But thankfully, we didn't lose any of our staff.
And what forms, staff support were you able to put in place? Because clearly the tax and the toll on staff is just enormous, as well. Was that something that you had to very, very rapidly mobilise and provide?
I think from my perspective, having been in the military and deployed on operations to Afghanistan and places like that, I was certainly aware very much around, the importance of, providing that support, and that debriefing isn't the right word, but that the incident management. And so for me, in the army, it's very much that TRIM process, the trauma risk incident management, which actually is used in a stressful environment. So it's very much trying to find something that would be useful in the NHS. And I was very lucky, actually, because as part of the education group, I was part of a WhatsApp group, another WhatsApp group with doctors, and a team of registrars, psychiatric registrars at the Maudsley, actually set up a COVID response group. And so I basically reached out to them and said, look, I'm a nurse, critical care, this is what's going on. And they actually came in and they provided us with the WHO psychological first aid. So what I managed to do was get a whole team of peer support people on critical care, through band 5s, band 6s and the band 7s, to actually become like peer psychological first aid support, and then we started doing virtual clinics, and then we had the support of the Maudsley team as the backdrop, so they were able to provide the support for our team until they got established. So we got things going ourselves because there wasn't really very much provided for us at the start.
Can I ask you, Chris, what kept you awake at night? Because it must have been, you know, as you say, a roller coaster. Were you one of these people who happily can sleep through this type of thing, perhaps through your military training, or someone like me who would be in heckle pins all the time and up all night? But
absolutely not. There were a lot of sleepless nights, and we were almost on call 24 hours a day, and there was nothing else to do. But you think people were phoning you and asking you questions, and I think there were sort of several things. I think certainly equipment was one of the stressors that did keep me awake. I mean, I do remember we had ventilators, but we didn't necessarily have the ventilator tubing, because that's disposable, consumable. And I do remember having conversations around how, can we get it re-sterilised? And it was, and when you think, when you're starting to have those conversations, they were like the stress of, are we going to run out of equipment like syringes? We ran out of drugs. It was just, we had, at times it was just so bare, those cupboards. That was stressful, just thinking, how do you even just maintain a safe service? PPE was a big stress, because the guidance was changing, and I'm sure the ward staff and people in the community will probably have had more challenge than we did, but it was constantly changing. And we were going from I remember going to one conversation where we were in full FFP with visors, FFP3 gowns and everything, and the next thing, in a few hours later, you can just wear a surgical mask. And it was like, it was very, and when you just think it was very, the guidance was just not consistent. And then it was, what happens if we run out of PPE? I mean, we were lucky with PPE because we always had it supplied. So I don't ever remember that, we got low levels, but we never sort of run out. But I think certainly our colleagues on the wards and, had challenges, and, everyone would just help out as much as they could. But those things were definitely, and I think my final thing that kept me awake intermittently or most was probably about staff welfare. And actually, just worrying, because actually if it goes wrong, you're part of that decision-making process, and you carry that weight, even though you've done everything you can. It's like, it's just, that was probably staff welfare, and, making sure that people were okay was probably the thing I worried about most. When people were upset, in tears, are they going to be all right when they go home?
Can you just share with us as well, Chris? That's brilliant. I mean, some of your key reflections on your experience, what went well, but what could have gone better. I mean, you've already alluded to some of those, but just some of your sort of take homes from this experience, if it's possible to kind of nutshell them in a way. I'm sure that's possibly.
I mean, I think it's hard, because I think, hindsight's a wonderful thing, isn't it? And I think, so actually when you look back, some of the decisions that we saw being made may not have been the best ones. And I do think that, particularly, some of the strategic managed things, I don't think people went out to necessarily make some of the decisions. They were doing the best that they could with the decisions and the resources that they had at the time with it. My sort of take-home messages, I suppose, was, for me, it was to have led a team, I have to say, that was just absolutely amazing. And the teamwork, the camaraderie, the can-do attitude, and, the balls of some of the staff actually knowing that actually, they're in a high-risk group, they're whatever, and they still put that PPE on and they walk through that door. And, that, it just made me so proud, and it is, healthcare and critical care is a team effort. But you know what it is? It was nursing work. the nurses spent the most time with those patients in PPE for 6-7 hours at a time. You know, once the doctors had done their rounds, once the physios had done their bit, it was the nurses that were left in that unit. And it was nursing work. And, you know, and it makes me proud to be a nurse. And, you know, the teamwork and, you know, the strength of people has been amazing. Lessons learned, I suppose, planning. I think one of the challenges, and I think I may have alluded to this earlier, was that it felt like there was this disconnect. And what was happening behind those two doors in critical care, you couldn't explain. Everyone knew we were running out of PPE. Everyone knew that we had like 30 ventilated patients. Everyone knew recovery everywhere. Everyone knew but it almost felt like there was a disconnect. And it was almost like it just felt quite disjointed. And I think probably improving that communication, but I don't know how you could, because it wasn't that people were ignoring the issue or not trying to address it, but it almost, by the time they found the solution, we'd moved on, we'd admitted more patients, or something else had happened, or, you know, there was an incident or something, and it was almost like it was this delayed reaction. So by the time you got the solution, it was almost like, well, yeah, you know, we've moved on from that. And I think that communication piece probably is something that would be something that one of those take-home messages to get it more joined up.
Mm-hmm. Sounds great. I mean, yeah, it must have generated quite a lot of different types of cognitive sort of dissonance, and yeah, you know, and uncertainty as well, and sometimes feeling empowered and sometimes feeling the opposite. As you say, that kind of roller coaster. I think we'll just leave it there for the moment, Chris. That was absolutely fantastic and so rich and textured. And I'd like to now invite Rose to respond to a few questions, but maybe there's a little question at the end that I can ask both of you, and then before we move into audience questions. But thank you so much, Chris. That was absolutely riveting and really, really brilliant. And you know, we owe you a great debt, you and your colleagues, of gratitude. So thanks, Chris. So Rose Gallagher, you've got a different story to tell, don't you? Very much from more of a sort of policy, perhaps a helicopter kind of view. It'd just be really interesting to get your perspective, Rose, on what your first memory of COVID actually was. When did you first hear about it? And when did you realise, because you have been in the eye of the storm before, when did you just realise that COVID, blimey, this actually is a pandemic? That would be really interesting to hear about.
I vividly remember Christmas last year, and when we came back to work after the Christmas holidays, a colleague sent me a message which basically said, watch this one, and sent me a link to some of the things that were going on in China. And we knew, even though there was limited information at that time, that there was something different about this. So it reminded us of SARS, but it wasn't quite like SARS. So I went on holiday. We went off grid. We were in Africa. And all through the holiday, I continued to receive text messages with the number of cases and the spread that was taking place in other countries. And I had the foresight to put things in place so that whilst I wasn't at the RCN, the national agencies could contact colleagues because I thought that things were going to move forward. And in fact, they did. So by the time I came back in the last week of January, it was really clear that it wasn't a case of if, but when we were going to have a pandemic, because for every few cases that were then being identified globally in different countries, there were many, many more clearly that weren't or hadn't been picked up. and that actually the situation was far different to what the data was reporting. So that was really my introduction to what was going on at the time.
And what was your initial reaction?
My initial reaction was to really try and understand what was happening. So as I said before, it was like SARS, but it wasn't SARS. And I remember vividly, even though it was at the beginning of my role in infection control at the time, the impact that SARS had on healthcare workers. All our planning had been done, our large-scale planning, on influenza. And influenza had been the one thing that had always, I suppose, frightened me as an infection control nurse, because of all the scenarios that we had done in pandemic planning and the history around the avian strains in particular of influenza. But this wasn't influenza. So my main concern was initially actually around the need to keep things calm. We had learned a lot from Ebola, that fear spreads much quicker than infection. And we were all watching the images on the television in China, and then subsequently in Italy, in Europe. And a lot of people were very, very frightened, and quite rightly so. But we somehow, as healthcare professionals, we have to hold the reins and reassure people, whilst not hiding the situation, that actually there are plans in place. We are stepping up to support them, to care for people, and to do our part, particularly as nurses. So really, for me, it was about just going into operational mode. You go into that zone of having a list, working through, and then just mobilising those around you to support you.
And does the RCN, it sounds as if there is a sort of clear protocol for responding to these types of events within the RCN?
So there was no,
this one was,
yes,
like...
It was, yeah. So we didn't have a written process for this, but we did have, as you said, the experience of the swine flu pandemic, MERS and Ebola to draw on. And one of the things I was really grateful for was the memory that we have internally. And if you look to certainly from England, but it applies to other countries as well, our health systems, our structures have completely changed. And I was concerned around loss of memory within those systems as part of the response to this. But internally, certainly, myself and Kim Sunley, who was with me through all the other three incidents, we were able to come together very quickly. We had written down learning from particularly the pandemic influenza work, and we knew instinctively what needed to be done and prioritised for members. So the first thing that happened was information on the website once we had got to that stage where it was clear that that as a nation or as a global community, we were moving towards something very different.
Perhaps it's worth just saying that Kim Sunley, am I right in saying this, is from employment relations and also an expert in health and safety?
That's right. So Kim's expertise is absolutely invaluable in this situation. And my colleague Helen Donovan, who leads on public health, and Anna Crossley, who has a military background but leads on acute and emergency care, the four of us came together to provide that initial response internally within the organisation with a range of skill sets, which really, I think, helped the RCN.
And what were you and this quartet, your quartet, what were you actually feeling at the time? Can you remember?
So my overarching feeling for me personally was about getting organised and making sure that we really went back to that learning from previous incidents and made sure that we picked out the right bits to work with at the beginning of the pandemic. was surprised, I suppose, on a personal level, at how frustrated I was that I wasn't in practice.
Mm-hmm.
And that actually surprised me, because I love my job at the RCN. I've been there 10 years and I've had a national role in that period, and there is a need for national leadership and a national contact point in the organisation in these sorts of situations. But my heart was really in clinical practice. Mm-hmm. And if I had been in clinical practice, I would have been walking the beat every day. I would have been in touch with what was going on all the time. And it felt as if there were gaps for me in the role that I had at the college, around what was happening nationally in decision making in particular. Mm-hmm. For the pandemic.
And what kinds of, if you like, responses and services were mobilised first? I mean, I certainly know about the RCN Direct and the helpline for members to call into. What if there's a sort of ABC of what the college did by way of responding? Can you give us the first three things?
So the first thing was to brief internally. So as soon as I got back from holiday in January, we started internal briefings. And once it became very clear where we were going with this, then there was obviously a briefing to the executive team, because we needed to make decisions internally in the RCN around how we protected our staff, because many of our staff go into hospitals. Our employment relations teams, those staff working in the regions, have very different roles to people like me who are office based in London. So we had to think about how we would respond to members' inquiries and how we would protect our staff at the same time. The second priority was then around information for members. So one of the big points of learning was that the RCN does not write its own clinical guidance in a situation like that. That is not our role. This is a command and control situation, and our role is to support the government and the national agencies around the pandemic response, and to make sure that the voice of nursing and the contribution of nursing is heard and recognised, because nursing, as Chris said, is the largest part of the workforce. We are the people that are with our patients, whether it's in the hospital, community settings, hospices, mental health facilities, whatever, 24 hours a day. And the impact on healthcare workers can be extreme. So we had to make sure we could signpost our members. And then the final bit in the jigsaw early on was really to understand what sort of concerns and questions our members were coming to us with. So that's where RCN Direct comes in. Mm-hmm. And I have to say, it was a really, really good experience to see the professional half of the college and the employment relations half of the college come together on this one issue, because it's very easy, for example, to write infection control guidance on how to put on PPE or how to take it off. But actually that can be impacted on by so many things that you wouldn't consider if you don't cast your net wide and get the feedback and intelligence of what it's like in different care settings. So it was fantastic to see the strength of the college in this situation.
Mm-hmm. And what sounds like the college was able to be quite agile. And what were the priority issues that were emerging for nursing staff? That would have taken a bit of time to coalesce, but...
Yeah, I mean, the first one, of course, was that we were dealing with a high consequence infectious disease. So when a new infection emerges where there is little knowledge about its impact and its treatment in particular, then it's classified as a high consequence infectious disease. But once you have been in that situation for some time and you have learnt more about it, these infections are often declassified. Not for everything. Some things like Ebola continue to be a high consequence infectious disease, but there is a path that is taken for things like new strains of influenza and coronavirus, for example. So PPE is absolutely crucial in those circumstances, but we know from previous experiences that when you talk about PPE in a situation that's different to business as usual, somehow staff doubt their knowledge and their competence and their confidence. So there was a lot of work to be done around PPE and reminding people, particularly around fit testing, and that fit testing is different, for example, to fit checking. So some very practical health and safety aspects, and reminding people about risk assessment, which I can come back to later. The other priority was about making sure people had access to the guidance, and to really try and get our foot in the door nationally, to bring the voice of professional nursing, not specialist nursing, but professional nursing to the table, so that whatever came out of the guidance cells was actually fit for purpose across all care settings.
And was a sense emerging, Rose, that there were some groups of patients and indeed possibly of nurses who were more vulnerable to the virus than others?
Yes.
Is that something you're becoming aware of?
So the two big things for me were obviously the effect on our Black and ethnic minority staff and care homes, actually. And I remember watching the television with my husband one night, and this was as we began to see more healthcare workers affected and unfortunately dying, and just seeing a sea of Black faces. And it really struck me that at that point there was something going on here that was different, even if we didn't quite understand what was causing so many people to be adversely affected by this that were healthcare workers. For care homes, I think I just felt at a loss, if I'm completely honest, as to how they seem to have be so unprepared and unsupported in relation to the provision of PPE.
Mm-hmm. Mm-hmm. I mean, how did that make you feel then? What did you how did you respond to that? In both of those sets of vulnerabilities, did the college then mount a lobbying response, an assertive lobbying response, to champion both of these areas? Was that what happened?
So they absolutely did. So there's a limit to what I can do as an individual, and I recognise my limitations. And again, this is where the college really came together. So it very quickly, obviously, lobbied for more and appropriate PPE. We worked very hard when it was clear that we were in what's called sustained transmission, that actually there were equal risks in community settings as to hospital settings, because we have ventilated patients in community settings. We have staff that are moving from home to home in community settings, and actually we did not know who had the infection and who didn't on many occasions because the testing was limited. So we had to really advocate on behalf of healthcare workers in all care settings. For the BAME community, obviously the RCN, and I have to thank our colleague Wendy Irwin, who leads on our inequalities work, was right in there at the heart of it, and drawing on her experience and lobbying the government to do more to protect Black and ethnic minority healthcare workers.
Mm-hmm. And was that part of the support mechanisms that were put in place, Rose? What kinds of support did the college put in place to try and help people in these groups?
So this is really where Kim Sunley came into her own. So drawing on the health and safety expertise, and also encouraging our members to remember that although we are in a pandemic, there is legislation, that there are things that should happen, and just because we're in a pandemic doesn't mean that we should forget those. So we did encourage our members to speak up if they didn't feel safe. We produced guidance on this. Once the report on risks associated with Black and ethnic minorities was published, then clearly the college did a huge amount of work on translating this and highlighting it to our members, which further reinforced actually the entitlements that they have to be safe in the workplace, the same as everybody does. And nationally, you know, with the discussions around inequalities and deprivation, the biggest thing that has struck me is how this pandemic is a pandemic of inequalities, despite the fact that we know the demographics from the scientists around age, obesity, etc., that will affect us all. But the impact of inequalities is going to be with us for a long, long time.
Yeah, I'm sure you're right in that, unfortunately. What kept you awake at night, Rose? What were your...
So I have to admit, I did not lose any sleep, and I feel terrible listening to Chris being up, and I know where he's coming from because I've been there with that. However, I have learned to personal coping strategies around outbreaks, incidents, and this pandemic, and I don't lose sleep. Other things keep me up at night. I had some early mornings, I will admit to that. Climate change keeps me up at night, but pandemics and infection control doesn't.
Wow, that's probably a testament to your competence and capability, or perhaps your learned behaviour and the fact that, you know, you've got that memory, that organisational.
Yeah, I think that's all it is. I don't have any unique skills or attributes or physical abilities at all. And actually, I was exhausted at the end of the day. But it's about contextualising. And my dad taught me something which I've never forgotten during the outbreak of Clostridium difficile that I dealt with about 15 years ago. And he really told me off one day and told me that I couldn't boil the ocean. And I've never forgotten that. And he's right. You can't. And actually, I learned a very hard lesson at that point, which was if I became unwell, if I overworked myself, I was no good to my colleagues and I was no good to my patients. And actually, that has to be my first priority. So self-care is something that you learn in these situations.
Yeah, very important for us all.
Yeah.
I mean, perhaps that feeds into some of your reflections on what went well and what didn't go quite so well. What are some of your key reflections from the pandemic?
So I'm really pleased at how the RCN responded in the early stages and subsequently. It's a very complex organisation, and it can be hard to get, you know, to amongst all the things that have to be considered and prioritised, sometimes to get infection control up there as a priority. But on this occasion, I have to say the whole machine swung in behind us, and that was great. My frustration is really around what felt like that lack of memory. So as I said before, myself and Kim came with memory. I don't think we could have responded in the way we did if we hadn't have been there, but the system has lost its memory. The structures of the NHS, the organisations, the people that make a response, whether it's behind the scenes or in the public's eye, simply weren't there. So to get nursing around the table as an equal stakeholder has been and continues to be a struggle.
Yeah, I hear you on that one. We've got to keep trying, and having nurses also seen as experts, I think, in their own right, Rose. It's always a bit of a battle.
Yes, I mean,
yeah.
But look, that's is that obviously when you have a pandemic with a new infective agent, pathogen, whatever you want to call it, the scientists and the science is absolutely crucial, so we understand what we're dealing with. But somebody has to deliver the care to those patients. So we need our medical colleagues and we need the scientists, but nurses have to be there, stood next to them as an equal partner and an equal stakeholder. And it hasn't felt that has happened all the time.
Rose, that's absolutely fantastic. And thank you so much for sharing your experience and expertise so generously with us. I think we're reaching the end of our event, sadly, because I think we could go on for another 2+ hours. It's been really a truly fascinating, and I feel a highly privileged ring seat series of insights and micro immersive experiences at the front line of care and the sort of policy level. So my heartfelt thanks to both of you for sharing so exquisitely generously with us this evening.